So I love sharing what I'm thinking about, what I'm learning about. I get to wear a lot of hats, like you heard. I'm the educational director for Progressive Medical, which is a large integrative clinic in the Southeast. If you're ever in Atlanta, stop by. I always think of it as the Disney World of integrative medicine. So we've got lots of procedures and interventions, and happy to share what we've done brick and mortar for the past 25 years. And then out of that clinical space came the birth of Precision Point Diagnostics. And so it is a laboratory, and myself and my partner, Dr. Gazzagoli, as the reason that we founded the laboratory is because we are working with patients. And what we were seeing is that a lot of times there were these very well researched markers that were highly predictive for things like cancer or heart disease, but weren't available to us as clinicians. And when you start to look at why that would be true, why could there be thousands of peer-reviewed papers talking about markers that were highly predictive, but not trickling down into the space that we might need them, where we could order them? And while I don't believe it's exactly a big blown conspiracy theory, the idea is that markers, biomarkers, should be utilized to diagnose a condition, to determine that ICD-10 code that you're going to utilize. And so there's less focus on markers that talk about a process behind a condition, meaning, are there nutritional deficiencies, or toxic body burden, or mental emotional stress, or inflammation that's often largely gut-based, or oxidative stress that can contribute to most of our conditions out there. And so the thrust of diagnostics was really to define an ICD-10 rather than the process behind the condition. So the mission of Precision Point Diagnostics was to bring to light labs that weren't as commonly available, but would help to shed light on these chronic pieces that happen in functional medicine. And so as I've walked through this for multiple decades, if one can believe that what we all wrestle with is, how do we provide the best quality of care to a patient that's individualized the most appropriately and that's manageable for them and manageable. And I know I'm still on my first slide, so if you're waiting for me to change slides and think I haven't done so, I'm getting there. And so this management of our patients, how do we move them forward in the most responsible way? And the most responsible way means what's most indicated for them, but we also have to balance, the logistics of it. We would love to order 20 tests on every single person and have, $10,000 worth of testing. And while a standard cardiologist or gastroenterologist doesn't have to bat an eye when they ask for their diagnostics, we in our functional medicine space do have to balance all of this. So if that's the case, what can we utilize to get patients off to a good evidence-based start? What can we utilize that gives us this informed decision making that's going to move our patient forward, but without weighing them down into too much of the nitty-gritty until we get that foundational piece in place? And so when I think about that as a clinician, what I know is that, and I am likely, preaching to the choir a bit, but so to my choir, or to our choir, I should say, what is it that we're worried about in most patients? Well, we are worried about functionally if there's inflammation that's gut-based. That's one of our huge pillars that we need to think about as a process. And we're also worried about detox, toxicity. And the reason that we're worried about toxicity is because it creates oxidative stress. And we know that's the primary process by which you might damage the DNA to set up mutations for a cancerous change. And or we know that when there's more oxidative stress from toxicity, this is what compromises every cell right down to the mitochondria. So the standard patient that comes in often is going to have similar complaints. We are going to see, 6, 8, 12 patients a day, and they are likely greater than 80%. And I might even put my thermometer up to even greater than 90% are going to come in with fatigue, brain fog, weight gain that they're not comfortable with, generally not feeling like themselves. And if that's the case, we know that in terms of fatigue, I need to rule out anemia, I need to rule out hepatitis, I need to rule out thyroid, I need to rule out adrenals, I need to rule out mold, I need to rule out Lyme, I need to rule out, rule out, rule out. And so where do we get started? So as I've walked through patient care and literature and thought about it, probably, every single day of my life, even most times while I'm, brushing my teeth or even in the shower, like giving a lot of thought to it. How do we cast a wide net that captures this process, but again, doesn't weigh the patient down? So when we think about it, we know most chronic conditions are driven by what happens in the gut. And I could be talking about cardiovascular disease, cancer, obesity, and I can trace all of these back to the gut quite easily. And we're going to walk through that. We know that when we look at gut markers, it's like a CRP for the whole body. We're looking at these gut markers because they tell us about inflammation in the gut that contributes to number one killer, cardiovascular disease, and or drives autoimmunity. And these markers can then tell us how somebody is responding to something. Also, if we have these good gut-based markers that say, you know what, your gut is leaky, let's get started on some therapy. Now I can monitor this marker every 3 months or so and make sure you're not leaky. Now I know this is a good time to help bring foods back in when the gut is less leaky. Now I know you're not on that autoimmune continuum as I might have anticipated as the gut is less leaky. Now I know that there's less risk of depression and brain fog as the gut is less leaky. So it gives us this evidence-based way to track what's going on. It means that, and we all know that we want to individualize as much as possible because that's what makes our treatment more effective. This is the beauty, this is the double-edged sword of integrative medicine. It's the beauty and it's the downfall. If I see somebody with depression, my tool bag isn't SSRI, it is, but it's not only that. And you might go, okay, well, there'd still be SSNRIs or that kind of thing. But I might realize that this depression is from inflammation because inflammation blocks the brain's ability to make serotonin. I might realize that this depression is from nutritional deficiency because there's not enough tryptophan to do so. I might realize that this depression is from gut-based inflammation because when the gut becomes leaky, we make more zonulin, telling tight junctions to open at the gut, but also open tight junctions at the blood-brain barrier, which is associated with depression and brain fog. And so as we through a condition like depression, what we quickly see is that it could be for numerous reasons, not merely a suppression of serotonin. So if I can say this is an oxidative stress patient, this is a tox patient, and they're toxic, and that's why their brain's not making serotonin versus they're more leaky gut, and I need to start in that direction, it gives us some really good decision making as we're getting those foundations in place. As much as we hate it, we wish that what fell from our mouth as practitioners was absolutely gold to every patient as they came in. And likely it is. Education, I do feel, is the foundation of really what is integrative medicine. To me, it's not a pill, powder, or potion medication. It's what we impart to the patient in terms of understanding about their body so they are empowered. So the education. But we know that when we engage with testing and people see numbers, they get more real about their treatments. They have benchmarks. They can track. They understand it's going on. And so that the part of treatment becomes much better typically with most patients out there. We can look at these oxidative stress markers because they are some of the most prevention-oriented markers out there. Our top two killers are cancer and cardiovascular disease. When our standard patient goes in and does their yearly checkup and they do their CBC and their Kim screen, what marker on there tells them if they're at risk for cancer or cardiovascular disease? Our number 1 and 2 killer. And we're left answering this question to patients, and we're left often saying, not a lot on here. We know you're not in kidney failure or liver failure, but those preventative assessments just aren't there in the same way. And so it's up to us to find them. That's a lot of work doing all that. And so we want to make sure that we're targeted. So at Precision Point, we've released the Gut Ox Stress Profile. And this is a well priced panel that can be done exclusively from home that starts to give us that direction. We do our foundational piece. We're looking at our chem screens and our CBCs, making sure there's not liver failure or kidney failure. But as we get started, as we decide, okay, am I going to put them on more of a gut-based protocol to start with or more of a detox protocol, we can begin to look at some fundamental markers. Zonulin tells tight junctions to open. Lipopolysaccharides, and I'm going to talk about this next, but when I think about what really gives us the most information in terms of a dysbiotic gut, if I think about where is the bulk of the research around this, you would have to say, and I've thought about this, how do you position something, how do you use something like this, like with a stool test? And ideally, I really think a stool test plus lipopolysaccharides would be more complete. And why do I say that? We know gut inflammation could be from foods, and we know it could be from bugs. And I'm not discounting the pathology that yeast or parasite or even various species of bacteria can bring. But if I go to the research and I say cardiovascular disease candida, if I go to the research and I say talk about obesity, diabetes, candida, I can find some things, but I cannot find the preponderance of evidence that you find with lipopolysaccharides. When I look at autoimmunity, LPS directly damages tight junctions and decreases Treg cells. So the type of leaky gut it creates and the continued impact on the immune system is hugely represented in the research. Why? Why is that the case? Well, the reason for that is because we all have bacteria that form lipopolysaccharides. We don't all have yeast. We don't all get a parasite. We don't all even get, extensive bacterial infections, but we all have commensal flora that forms these lipopolysaccharides. So there's a greater risk. And we talk about something like metabolic endotoxemia, that thing that drives cardiovascular disease as we age. That is from LPS. So when I go to the research and say LPS and limit clinical trials and conditions, there's way more specific data here than there is with any other single dysbiotic agent otherwise. And so as a screening tool, it's a great place to start. We all know secretory IgA, 80% of the immune system. I'm going to argue that it's even more than that, because what it does in the gut primes the systemic immune system and changes beta cell function to B cell function, changes T cell function, changes what natural killer cells are doing. And so that signal from the gut, even though right there in the gut, it's 80% of the immune system, it signals the rest of our immune system. So again, globally, a screening marker, what gives us the most information, this really hammers that home. We know glutathione's the major intercellular antioxidant for the liver, for the brain, for the kidney. We know that you have to have glutathione to decrease viral replication. We know that glutathione, when it's low, you're more at risk for things neurologic, not just Parkinson's and Huntington's disease, but also central nervous system, depression, anxiety. Markers of oxidative stress, and I'm going to talk about each of these in more detail. That F2 isoprostane, when it's high, it means your fats are crunked up. They're not working like they should. Your brain is fat. Every cell membrane is fat. The myelin sheath is fat. So if that is high, you're more at risk for things neurologic, depression, neuropathies, less cell membrane fluidity. So an association with not just cell health, but mitochondrial health. And 8-OHDG, I've been, jumping up and down about this one for years. But again, don't take my word for it. If you are if you need to fidget a little bit, go into PubMed, limit clinical trials by humans, and look at the preponderance of human data that talks about when 8-OHDG goes up, we're more at risk for a cancer. If we get a cancer, it's more likely to be aggressive. It's more likely to cross the blood-brain barrier. There's more likely to be angiogenesis. But not just cancer. 8-OHDG goes up when there's DNA damage. We also have DNA in the mitochondria, so it's a great mitochondrial marker. Back to that initial example of fatigue, how do we know? Is it thyroid? Is it adrenals? Is it the mitochondria? This screening profile gives us those markers to do that. Okay, so why did I choose some of these? All right, so yes, I am a big believer in stool testing. Most of my patients will get a stool test initially. body. But if I can do LPS alongside that, I really, really think that makes a lot of sense. And there's some times where I think, it becomes more necessary than even some of the markers on stool tests, meaning like autoimmunity, and we're going to look at that. But lipopolysaccharides might be the most important marker in terms of chronic disease. The reason I suggest that is because let's look at what's happening in lab sciences. If I am in an academic lab and I want to create an autoimmune model in a mouse, the way I do it is I inject it with lipopolysaccharides. And the reason that you do that is, again, because it will damage tight junctions. And we know that that leaky gut is an onset for autoimmunity. Fasano taught us so much about that, was zonulin telling tight junctions to open. And his research went on to demonstrate that zonulin goes up even before the onset of autoimmunity, because you have to have the leaky gut to create the stress on the genes to cause the autoimmunity to express itself. Okay, so, but then why not just like inject a bunch of zonulin into these rats? Well, because LPS has a beautiful one too in terms of wreaking havoc on the immune system. Not only does it make those tight junctions more leaky, but it binds to Treg cells and decreases their activity. Those are the ones that keep the immune system in balance, T regulation. And so now, and let's say it this way, a hallmark of autoimmunity is a downregulation Treg cells. LPS directly does that. Another hallmark of autoimmunity is that is upregulated toll-like receptors. I always tell patients they're like a little antenna that are sending out signals like a siren, attracting more white blood cells to the area, really amplifying that inflammatory load. So those are, again, so LPS also increases toll-like receptors. So low Treg cells, high toll-like receptors, two things that are evident in most autoimmune conditions, LPS directly causes. So also, if I want to create depression in a lab model, I also inject LPS. Too expensive to design a genetic knockout model that doesn't create serotonin, just inject that LPS, because again, it blocks the brain's ability to make serotonin because it increases IL-6, IL-8, TNF alpha. All of those block tryptophan from going to serotonin, move it to that NMDA agonist that will make us feel more achy. And if that's not enough, it also drives metabolic endotoxemia. So when we talk about this metabolic endotoxemia that happens with aging, that is lipopolysaccharides that's in there drifting into our body, damaging LDL, causing it to be oxidized, damaging the glycocalyx. If you want to cause the glycocalyx, the inside of the vessel, to just shrivel, you plate a bunch of LPS and ox-LDL next to it, and you see that the health of the vessel recede. So when we're talking about things that drive cardiovascular disease that start in the gut, LPS is so well represented in the literature. So this LPS is what has been identified to get into the bloodstream and cause chronic low-grade inflammation systemically, and that is defined as metabolic endotoxemia. That is LPS. As LPS comes in, it causes an increase in obesity. First of all, it's damaging to the gut, so you're going to get less release of GLP-1. That signal starts to go down. So if we're transitioning people off either natural or otherwise GLP-1 agonists, cleaning up LPS is a great way to get them to the next part of where they're maintaining weight on their own. But that being said, LPS also systemically increases LOX receptors, and those turn on signals to increase obesity as well. LPS damages insulin receptors, drives a type 2 diabetes. Again, also when you cause more leaky gut, that also causes diabetes. Fasano, in fact, as he identified zonulin, said, look, all these diabetic patients have huge amounts of zonulin. Zonulin goes up because of the food they're eating. The food they're eating creates dysbiosis. That causes LPS, damages tight junctions. Now, everything from the gut floods in. We know that story in terms of the immune system, but that oxidative burst that happens from leaky gut also damages our insulin receptor and increases risk of atherosclerosis. LPS is a beautiful way, like I said, to make that vessel damaged, and that damaged vessel is a lovely place for a cholesterol to sit. Also, LPS activates macrophages, so that step process that we need. So LPS, highly implicated in cardiovascular disease because of the inflammation. It damages your glycocalyx. The LPS directly prevents reverse cholesterol transport. That is what HDL does. It brings the cholesterol back to the liver to be broken down and to be utilized. LPS gets in the way. You can't do that anymore. So what's the problem with our ApoE patients? Well, that ApoE SNP is a SNP in reverse cholesterol transport. So if we're trying to pad their reality and make sure that they're not, as a word, we're doing things to decrease their risk, we've got to get rid of that LPS because it's directly inhibiting reverse cholesterol transport, and their SNP meant they already had a problem with that in the first place. That's what ApoE does. When it's normal, we have good reverse cholesterol transport in the brain, and this helps us prevent Alzheimer's, moving those fats around like they should. And like I mentioned, the toll-like receptor, so highly implicated. So lipopolysaccharides increase our risk of obesity and insulin resistance, dyslipidemia. They also create oxidative stress. And so this is how we have metabolic endotoxemia that drives cardiovascular disease that people tend to associate with aging. I also think it's really interesting to drill down on the dynamic of pain. Pain, tends to be something that needs some other answers. Our standard answers that exist in society right now are medications that are highly addictive. Why wouldn't they be addictive? Of course, people are addicted to not being in pain. What is it? Addicted to feeling normal? So who can hold it against anyone? We all want to eliminate pain and feel normal. So it's easy to see why these things would happen. So, for example, when you are more obese, which lipopolysaccharides cause, you're also increased incidence of chronic pain. And so this research was tracing pain with obesity through abdominal pain, pelvic pain, neuropathic pain. Yes, our irritable bowel disease patients will have more abdominal pain from lipopolysaccharides, first off. Then they cause more obesity. Now that obesity decreases adiponectin, increases leptin, makes us hold on to more weight. That fat tissue has that metabolic activity to send out inflammatory mediators that are associated with even increased pain and irritable bowel disease. So you see the kind of the global and the multi mechanisms that these markers have. Not only does LPS make you more leaky, which makes you obese, but it also changes the fat cells too. So really this wide reaching impact. So when we gain more weight, it's not just that our knees hurt because of the weight. Remember that fat tissue making more leptin. Leptin eats up the cartilage in the knees. So osteoarthritis, yes, it's the weight, but it's also what's happening with that metabolic tissue as well, which lipopolysaccharides contribute to. So as you have more LPS, and this is from Brain Behavior and Immunity 2020, you'll have increased musculoskeletal pain because of cytokines, and that changes your mood, and it means your pressure points are more tender, and there's an increase in TNF alpha. Now, look at chronic conditions driven by TNF alpha, most of them. So if LPS is elevated, this gives us a go-to for most chronic conditions. All right. So secretory IgA, this one's very familiar to us. We look at it on stool testing, and when we look at it, we can look at it through saliva as well. And it represents 80% of the immune system. So it's critical. It's our first line defense. It's there in the mucous membranes, and it represents 15% of the total immunoglobulins produced throughout the body. But when our secretory IgA goes up in the gut, what we know is we're fighting an infection, and that's good. Our immune system's engaged. It's doing what it should do. So if we see it high on the test, we know, look, we don't know what infection is there, but we know you're fighting some infection. So getting started on our natural antimicrobials and tracking the secretory IgA, if it comes into range, we know whatever was there, we've treated appropriately. And if it doesn't, now let's reach for, some more in-depth stool testing testing to see, all right, what pathogen did we miss? What sensitivity do we need here to be more directed? Also, on the flip end, when secretory IgA is low, first of all, we know we can't fight things in the gut the way that we would like to, but when it's low, it speaks to the rest of our immune system. So a bottomed out secretory IgA says, you know what? For some reason, the immune system's not intact. So first of all, now create an oxidative burst to even commensal flora. So think about something like SIBO. And so SIBO, we know that those are often just normal flora that get into the wrong area. If it wears down the immune system and secretory IgA is low, now in the small intestine, it says, you know what? This must be a pathogen, the way it's eaten away at our immune system. Boom, oxidative burst. And we start treating that commensal bacteria like a pathogen, and it gets way more aggressive what's happening in the gut in terms of dealing with it. So more oxidative stress, more opportunity to continue to wear down the gut lining, but also a low secretory IgA in the gut sends signal through lymphatics to dendritic cells to say, we're under attack. And so systemic immune system, you better ramp up. So IgG goes up, IgE goes up. You will fight mold aflatoxin more aggressively. You will fight, which we don't want to do, right? It's usually an over stimulation. You will fight foods more aggressively. So when secretory IgA is low, your titers to IgG foods, your sensitivities stay up longer. Your titers to allergies stay up longer because the systemic immune system says something's going on out there. We better be on heightened alert. And so it's a reason that you'll become more inflamed systemically. When that lining goes down, it says to the rest of the immune system. And so this tells you, okay, they're likely on the autoimmune continuum. If you saw, low overall immunity, but they're cranking to LPS and they're fighting that and zonulin's up, you know that person's on the autoimmune continuum. Often we'll have people come back with a positive ANA screening for autoimmunity, but nothing else comes back. And you're left going, what should I do? Okay, well, these are all like pre-autoimmune markers. Zonulin goes up before the onset of autoimmunity. LPS is damaging those Treg cells so they don't work. Secretory IgA, when that goes down, the systemic immune system goes up. So it's a beautiful way to step in and see where is there some discombobulation. So here we see that secretory IgA. At first, what happens, of course, when we're leaky, the first response is to produce more secretory IgA to fight this infection. But then eventually, our resources run out, we can't do it anymore. And when it bottoms out, then these T cells become more inflammatory, where there's an increased push towards a Th17 response that goes up. That's what created that COVID cytokine storm. So definitely a highly inflammatory branch of the immune system. But Th17 is also irritable bowel disease, rheumatoid arthritis, Lyme, various infections, various co-infections, highly inflammatory. So that being said, secretory IgA has meaning on the high end, on the low end. When we see it cranked up high, you're fighting an infection, at least the immune system's still in the game. When it's on the low end, immune exhaustion, but also stress as well. So if major conditions out there can be caused by, nutritional deficiencies, oxidative stress, inflammation from the gut, toxic body burden, and mental emotional stress, a suppressed secretory IgA, this is why you see it on adrenal stress test, because it can be even more fragile than change of cortisol response. Some people really feel stress more in their immune function than they do in, their cortisol response. And that's why you want a diversity of markers on various panels that you're looking at, because different compartments of the body can be more fragile than others. So if you are a college kid and you go through finals, they will do things like track salivary secretory IgA to look at that stress response. So you get done with that stress, you get through your finals, and you're always kind of wondering, well, why do people get sick after their finals? They were hanging out by themselves, they were in smaller groups, they were studying, they were focused, they got done with their final, feel really good about it, time to celebrate, gonna go out, gonna party, maybe gonna have those beers that you'd been putting off as that college student. that secretory IgA stays suppressed for the next 2 weeks, even after finals. And so I would suggest that finals are a type of stress. They're a good stress, but yeah, I mean, like they're pronounced stress, but I wouldn't say that they're the largest stress that we ever face in life. So to think about your immune system staying suppressed for 2 weeks, even after a final exam. Now let's think about loss of a loved one or change of job or something going on with our kids or even our pets, so low secretory IgA can absolutely, trigger us to say, hey, what's going on in your life in terms of a stress response? Because I'm very sensitive to that. So also, if you see a low secretory IgA, like I mentioned, you could be fighting an infection for a long period of time. And there's certain infections that tend to degrade secretory IgA more so. So blastocysts, one of our parasites that show up, candida is really good at compromising secretory IgA. And so it can even give us a clue if secretory IgA low is, if secretory IgA is low, where's the immune system at? What's the stress level like in the patient? And have they been fighting a long-term infection? This really starts to push us in that direction to look where next. And so, like I mentioned, when secretory IgA is low, this too results in more oxidative stress because the body says something's tanked our immune system. We better create more oxidative burst out there in the gut to try to kill something. And so, that will, the cytokines that start in the gut don't stay there. They create systemic inflammation as well. And it creates a lot of inflammation. Here's a nice schematic just showing us that those glucocorticoids, those stress hormones, they love, here they are, blocking building of secretory IgA, blocking conversion, blocking decreasing not only in the gut, but, everywhere there's lining in the kidneys and the lungs and the bladder, all of those, the nose, all of this has secretory IgA, and stress is very intimately involved in causing a drop off of it. And, conversely, we can treat it. So there's just plenty of studies that say secretory IgA goes up, secondary to things like probiotics. Here's a study where they're looking at infants with colic. And what they saw was, yes, the probiotics cause a nice jump in secretory IgA. And when you saw secretory IgA go up, crying went down, colic symptoms went down as well, just demonstrating that it's a good clinical marker. It tracks with clinical improvement, and not just kiddos who are colicky, but across the board. So here, looking at double-blind randomized trial in terms of adding in probiotics, and what you saw was, yes, secretory IgA went up from that, as did IL-10. That's that one that tells us to be less reactive. And when secretory IgA went up, you saw also an increase in things like short-chain fatty acids. You saw a decrease in other systemic markers. So again, it's meaningful. It tracks well with these other things that we want to know about. Here, like if you like, again, it's just a demonstration of how intimately it represents immune function. If secretory IgA was low, it was lower in kiddos that were on, formula versus those that did formula plus pre and probiotics. So, and remember, this test is finger stick, saliva, and some urine. So it's good for kiddos as well. So we have maybe a kiddo whose gut's not doing as well. This is a real easy way to get started to see what their gut immune system looks like, and then treat, because probiotics will modulate that. Here again, and this is fascinating. So secretory IgA, a bit different from celiac disease versus irritable bowel disease. So it goes up in irritable bowel disease, fighting. Something like celiac, where you've got basically antibodies that come back and attack the gut lining, you see a decrease in secretory IgA. So they're having gut-based symptoms. We even can get a distinction of which direction they're more likely in. We're probably going to remove gluten for all those people, but still can help. We can begin to differentiate with some very global markers that cast a wide net. So here's that piece I was talking about. All it takes is a test to tank your immune system for even the next couple of weeks. And here's a schematic near and dear to our heart that would also let us know, okay, maybe our patients, we've got to do the basics first. Are they eating right? Okay, so they come in. 9.9 out of 10 probably are not getting 20 to 30 grams of fiber. So that fiber may be one of the major things that drives microbial diversity that will then send a signal to the cell to tell it to produce more secretory IgA. So again, we see low secretory IgA. We know their diversity is low. Their short chain fatty acids are low. We've got a lot to jump in and do and to get started with, and then move as we see things in another direction. So when the gut is leaky, this creates more IL-6. This causes the liver to make more CRP. It is directly inflammatory systemically. We showed how LPS also increases things like TNF alpha. That creates a systemic response as well. We know when there's more inflammation, we produce less neurotransmitters. We can't send a good signal on the vagal nerve anymore. That's going to even do things like make us more responsive to pain. And we know if we have a good, healthy microbiome represented by nice, robust secretory IgA, also low zonulin, low LPS, we're going to make less inflammasome. So this is that pain part as well. All right. So you can see, and so again, if we said, okay, let me look at a fecal bacteria pneumonia, one of the bacteria that we get from a stool test, and said, let me see how many studies there are with cardiovascular disease, with depression, with autoimmunity. We wouldn't see the breadth that we see with LPS because all of us have bacteria that can shed lipopolysaccharides, but has our immune system become overly excited to it? Are we fighting it too aggressively? That's when we get symptoms. So this is why it wreaks such broad havoc, because we don't even have to have an exposure. We harbor it, and it's a matter of, does our immune system control it? So that's why it's such a global marker. Believe me, I am never saying don't do a stool test. I'm saying in an ideal world, we'd be able to do both. But if we were starting with some screening, this is a good screen to tell us next steps. Okay, zonulin. So this was one of the first. So must have been a long time ago, because I was trying to see, I scanned this in years ago. I had chopped the date over here though, but it was at least long enough ago that people still got a newspaper in a print form. So decades ago, I remember this coming out, and this was in the Sunday Review of the New York Times. It was Susano talking about how, because we had quit breastfeeding and because of using all this junked up food, people were becoming more sensitive to gluten. We were seeing an increase in zonulin, and that's why we were seeing the increase in autoimmunity and more inflammatory conditions. And you got to love the guy. He certainly can speak the functional language well. The title here, All Disease Begins in parentheses, Leaky Gut, Role of Zonulin Mediated Gut Permeability and the Pathogenesis of Chronic Inflammatory Disease. And so here, he talks about, when you look at clinical studies and you look at when there is an elevation in zonulin, that means you're going to see more chronic inflammatory disease. You're going to see more autoimmunity. You're going to see more cardiometabolic, even more tumors. And so it's a big deal. It governs its permeability. And so his language is always so sexy, I think. Living life on the edge of the wall, like this rock star kind of mentality around discovery of zonulin. And I'm the first to be the groupie, because we all fell in love with zonulin when we learned there was a biomarker that told tight junctions to open. When you could identify this process of leaky gut, it brought clarity and it brought validity to what we had been doing for decades. So tons of research about zonulin modulating these tight junctions. When it goes up, there's more autoimmunity. And also we're not just stuck in place, there's so many treatments. So a polyphenol rich diet decreases zonulin. I love immunoglobulins like serum derived, like prescription, or, egg derived, colostrum derived, because they look a lot like a molecule of zonulin, and they sit in the receptor and block it from binding. So we immediately shut down this source of inflammation. So when we have the marker, it directs the treatment, and we can see directly what's going on. So, and here, probiotics, again, it's not just academic, because again, here are probiotics, and they decrease serum zonulin. Our immunoglobulins do this, killing the bacteria. And so what we know is that, for example, the gluten comes in or bacteria, and we're starting to see virus, even mold, as a reason to trigger this release of zonulin. It pops up, it binds to receptors, it tells tight junctions to open, and things flood through. It's a beautiful marker. And I love his language. He says, that this paradigm subverts traditional theories that underlie the development of these diseases and suggests that the process can be arrested if the interplay between genes and the environmental trigger is prevented by reestablishing the zonulin-dependent intestinal barrier function. And what he means is that environmental trigger is not toxins, it is zonulin telling tight junctions to open. It creates this oxidative burst, washes over our genetics, and where our weakness in genetics are, that's where our pathology tends to express itself, which is why zonulin can be associated with things all the way from autoimmunity even to cancers. There's so much research with zonulin and cancers. They're even starting to suggest maybe we use it as a screening marker in some types of cancer. So here's where he talks about even type 2 diabetes, not just type 1, because we eat that bacterial food. When zonulin is up, it pushes us more towards this Th17 response, that more inflammatory part. And here's from Pisano. He says, yep, you eat that diabetic food, it increases certain species of bacteria, and that too causes this release of zonulin. Here is the gut of people non-diabetic, much more permeable in the gut of people who are diabetic. So we can see this connection between so many conditions out there. Now, again, why I'm suggesting it as a really nice screening marker. Okay, so zonulin. When zonulin is high, there is even an association with PCSK9. And so we know, for example, we use PCSK9 inhibitors to lower cholesterol. So when zonulin is up, PCSK9 goes up as well. What that means is we're not recycling cholesterol in the membrane. And so that means that that's another reason for hypercholesterolemia. And also you'll see it in more obese patients. Let's say it a different way. One of the things that we often use to treat zonulin are botanicals that have berberine compounds in them. Why? Because they're antimicrobial, and bacteria is one of the things that triggers zonulin. Also, we know berberine lowers cholesterol. It increases reverse cholesterol transport, it decreases glucose, but again, another mechanism may be killing off this bacteria that becomes problematic in terms of the type of cholesterol that's formed. So zonulin tells tight junctions to open. LPS will not only damage tight junctions, but it will inhibit zonulin occludens. So we're getting a picture of both the opening and the closing when we're looking at zonulin and LPS. And there's so many of those markers that are involved in closing. LPS interferes with majority of them. So it gives us a global look at that as well. Okay, so we can start off with our patient and we can get this picture. Or do they have high zonulin? Are tight junctions open? Are they fighting all this LPS, which is creating inflammation? And what's the global immune system looking like? Then we have some ox stress markers, glutathione, F2-isoprostane, 8-OHDG. I'm probably going to need a part 2 of this, but I'm going to go through these because you know 8-OHDG pretty well. You're used to seeing it in a number of places. Your organic acid testing for one, your urinary hormones for another. And the reason it shows up on so many tests is because it's so well researched. Again, I play the PubMed game, go in, limit by clinical trials, and look at 8-OHDG. You're going to see thousands of studies that say it increases our risk for heart disease, it increases our risk for cancer, it increases our risk for diabetes. And you know how you treat it? Antioxidants, clean diet and lifestyle, all the functional things that we're trying to do. And so I love this marker because it's a nice screening marker. So when it goes up in response to toxicity from the environment, mold aflatoxin, cigarette toxins, things that are in the air. So it doesn't tell you what toxin you're reacting to, but it tells you if you're at body burden. And as clinicians, that's what we want to know. And it gets really hard to measure every single chemical we're exposed to, because we know if I take a sample from the umbilical cord of a newborn baby, already over 1,000 chemicals there. So to look at every single chemical and to look at every single aflatoxin and to look at every single exposure to what's in the water and the cigarette smoke in the air, is prohibitive and quite frankly impossible. But if this is elevated, it tells us that there's too much toxicity and there's damage to the DNA. 8-OHDG goes up as a repair mechanism. So you know whatever the toxin is, you're at threshold for that cell because damage is being done. And the real place that we get most of our damage is not the DNA in the nucleus. It's the DNA in the mitochondria. And so there's a lot of research that says elevations of 8-OHDG is a very good indication that your mitochondrial DNA is stressed, which is going to mean less production of ATP. So that being said, these next few slides, so you're going to see everything's referenced in research. So I just want you to see that there's really, okay, pick your favorite air pollutant. I don't know, mine's benzene. What's yours? Diesel exhaust. Anyway, so there are plenty of PubMed references for whatever that air pollutant is. 8-OHDG goes up in response, or tobacco smoke. You see much higher levels in to people who smoke tobacco than those who don't, demonstrating the connection between oxidative stress or even wood smoke, cooking fires. Urban air pollution causes 8-OHDG to go up. And remember that study that just came out this year that said women who are exposed to more outdoor air pollution or at increased risk for dementia. So this is a marker that would tell us, are we at threshold for body burden? Do our detox protocols. And so recently I went through the academic exercise of saying, what are the toxins we're most likely exposed to? Let's look at them. Okay, there's about 4 or 5 that are really most predominant in the environment out there. Then I was like, what detoxifies these various chemicals? And I think I even extended my list out through the top 10 that are in the environment. And over, it's the same things. It's increasing glutathione, and sure, sometimes a little glycine or sometimes a little sulforaphane or whatnot, but it's those strategies that increase glutathione that detox our major toxicants out there. So if we see an elevated 8-OHDG, we know to jump in with our milk thistle, our glutathione, our sulforaphane from broccoli sprouts, all of these strategies, because 8-OHDG goes up in response to pollution from food, from metals, from the environment. We see an association with almost every cancer out there. It predicts occurrence, aggression, improvement, reoccurrence. You have somebody who's status post-cancer and they're in remission and they want to know what they can do to stay there. Beautiful data with keeping 8-OHDG low and staying off the brink of danger. But there's also an association with cardiovascular disease. You'll have an increased risk of MIs or congestive heart failure when 8-OHDG is high. You have an increased risk of systolic heart failure with high 8-OHDG. Inflammation, oxidative stress is bad for the body, and it shows up over and over and over. Yet when our patients come in for that once a year, where are you at? What's giving us that information? Nothing on a standard workup from, and nothing on your chem screen or CBC. So adding something like this in gives such good direction in terms of so many things, even beta blocker therapy efficacy. It goes up when there's blood sugar issues, type 2 diabetes, metabolic syndrome. So, and symptoms like feeling dry skin or all these detox symptoms. Are you more fatigued, brain fog, dry skin? So if HDG is high, you're more than 5 times likely to have one of these symptoms below. You might never figure out what the toxin is, but you can see it's impacting the body and treat accordingly. Okay, also to round out the profile, glutathione. And so glutathione here is an example of when we increase glutathione, we decrease pain and things like osteoarthritis. Here they are looking at pressure rats could put on their paws, and they do much better when glutathione levels go up. And so when we look at the model of pain, we know that as we increase NRF2, and that is the transcription factor that produces more glutathione in the body and increases antioxidant response elements, pain goes down from that as well. So there's all kinds of ways we can increase glutathione, from giving it to eating an organic diet, but it lets us know that our patients are at a toxic body burden. And so when glutathione is low, we are more at risk for depression, because glutathione is the major intercellular antioxidant for the brain. When you biopsy the brain of people postmortem who have depression, anxiety, OCD, they have lower levels of glutathione in their brain. We know that glutathione is that low glutathione is necessary for viral replication. We know that glutathione is the major thing that protects the liver in terms of detox. We know it drives phase 2 glutathione conjugation. We know that it also protects lung tissue, that it protects kidneys, that it protects the mitochondria. So very important to know that major intercellular antioxidant status. It's so preventative. Okay, finally, F2 isoprostane is on there as well. And so this is a marker that goes up when your fats are angry. So you take arachidonic acid, you hit it with free radicals or oxidative stress, it becomes F2 isoprostane. And when F2 isoprostane is high, it means that your fats aren't functioning. Your brain is fat, bone marrow is fat, the membrane of each cell is fat. And so when F2 isoprostane is high, it means you're not going to convert your DHEA into neuroprostanes. It's one of the most reliable markers of oxidative stress. It doesn't change with diet. It doesn't change with how long it sits on the counter after it comes, we look at it in urine, for how long it sits there. It's really, really stable. It's one of the major fats that you'll find inside an atherosclerotic plaque if you biopsy it. And there's extensive literature that talks about when F2 isoprostane is high, you're more at risk for things neurologic, fats, you're more at risk for things cardiovascular, and you're more at risk for cancer. The major three things that we're trying to prevent in terms of aging and decline. So, like I mentioned, it's great on the lab side. It's really stable. It's not affected by what's in the diet. It's really treatable with antioxidants out there, fat-soluble antioxidants, but really your sulforaphanes and your curcuminoids will also lower it too. And you don't see it vary from day to day. So it shines as a marker that's very stable and very predictive. Okay, I mentioned this about glutathione, but I'll wrap it up here. Like knowing our levels of glutathione are hugely important. It is the major intercellular antioxidant. As glutathione declines, process of aging increases. It drives detoxification. When levels are low, this signals that we're at toxic body burden. It protects the mitochondria, so it's associated with better energy. It's critical in the brain, the liver, the lungs. It helps with viral. When glutathione is low, that is the environment that viruses prefer, whether we're talking COVID, whether we're talking EBV, whether we're talking MS. A glutathione environment allows those viral loads to continue to divide, replicate. It's anti-aging. It improves the activity of stem cells. Global. It's a very global marker. So as we get started with a patient, we're really working to understand from the history what's going on with them. And are they more gut-based? Are they more toxic, more oxidative stress? And so some good global markers with this give us some good direction. So when we're thinking about, okay, there's so many tests out there, how would I use this test? Okay, so maybe as a starting point, you know that they're probably leaky, they're probably toxic. You get back your chem screen, your CBC, they're no problem with liver function, kidney function, and adding this on. So now we know, okay, probably more of the gut-based piece first. We'll start there, but there is some stress, so we'll do some toxicity piece next. And it's priced very nicely that it can couple with those basic markers. Also, it could be done from home. So in terms of maybe you did your functional assessment, you looked at those basic pieces, you got them started, an elimination diet, a detox protocol, and now they can do this from home. So when they come back, now you know how to tailor more. What are your next steps from there? Or you've worked with the patient for a long time and they have done your Lyme patient, your mold patient. And so I was just talking to a friend, a practitioner the other day, and she was saying it was a mold patient who had done very well. Aflatoxins were down and she was feeling somewhat better, but not quite there yet. And so they wanted to see, okay, well, what else do we need? Okay, aflatoxins are down. So the exposure is gone. How about the damage to her system? Well, it turned out her 8-OHDG was off the chart. So the practitioner knew to keep doing these glutathione therapies, keep doing the mitochondrial therapies. The fatigue wasn't coming from the mold anymore. It was coming from the damage it had done to the mitochondria. And so as she treated that 8-OHDG, she saw the fatigue remit. So to spot check somebody who has very far on the functional road, but they're not responding like you should, what's still going on that could have been missed? So that's how I am utilizing this test. And I just want to let you know that this is available at Rupa. We call it the Gut Ox Stress DIY. And We really wanted to keep this at a reasonable price point for getting started. So $349. But if you couple it with our food test, which is also done from home, that's the 88 food antigens, and you're looking at 4 different ways you react to them. Doing both of those tests together, $469. And so really a lot of testing from Precision Point, just want to make you aware of. So we do food sensitivities, and you can do that either from serum or a finger stick. We do bill insurance. And then also this intestinal barrier assessment has many of the markers that I just talked about, but also diamine oxidase. But what I wanted to draw your attention to was some of the bundled pricing. So if you're doing the intestinal barrier assessment that has zonulin, LPS, and DAO, as well as food sensitivities, here's a bundle price. Or you want food sensitivities, gut-based markers, oxidative stress markers, and adrenal stress markers, here's a bundle price. So look for some of those. We know when you're trying to do more testing, it's difficult. So we've looked for strategic ways to put these things together for you to help make it more accessible for the patient. We also do some thyroid and some hormone profiles, and even our basic wellness profiles get you started with cardiovascular markers, hormones, thyroid, nutrients, immune function. So a lot of bang for the buck in terms of everything that is on there. And so thank you so much for being here with me today.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.